There are a lot of evolution, I think, in oncology because of targeted treatments. And while some years ago, mantle cell lymphoma was a fatal disease with a short median survival, with the apparition of new targeted treatments, changed the situation very much. That's now very different, and there is some hope for these patients. That changed the way we have to manage this kind of patients. Indeed, if we had palliative treatment, the objective is quality of life, so that's not very much difficult. You can decrease the treatment as far as the situation of the patient is keeping not too bad. If we have a chance to better control the disease for a longer time, you have to deal with maintaining the chance of the results of the treatment to the best level without not too much increasing the toxicity and so on. In this case, when you are dealing with the elderly, well, you have to use a geriatric oncology approach. And the mantle cell lymphoma is really a disease of the elderly because the median age is, in population-based series is about 75. Well, in clinical trials, it's about 65 to 70. So that's the usual selection we observe. So that tells a lot, I think, to the geriatric oncologist. First, that we have to push a geriatric oncologic approach with a screening, geriatric assessment, and so on. And second, that we have to work with the clinician on a more daily basis to improve our management. I think that's something very much important. The targeted therapies are very much adapted to the elderly because they are supposed to be more specific. So the ratio between efficacy and toxicity should be much better. First, that's positive, so that would push the elderly to receive this kind of treatment. Okay. Then we still have problems to solve. The first one is that it's very costly, so there is a society decision. It's not the physician to take this decision, but probably to participate in the discussion. How far should we push this costly treatment in the elderly? Well, I'm not saying that we shouldn't treat elderly patients. We should, but we should treat if we have a reasonable chance to get good results. So we have to be cautious with that. We have to work in the elderly population, not in younger patients. We have to work on predictive factors of a good outcome. I think that's something we have to take into account. I think that's very much positive to have a session for young physicians involved in geriatric oncology. We need young physicians to be involved in geriatric, but they are the future, so that's very much positive. I'm very positive about this session also because they were very much active. There were a lot present in the session, so I think, well, that's just what we have to do, and we should help them. Well, in my presentation, I was talking about what to do. Well, it was very much simple. Well, you have to be clear on the topic you're working on. You have to keep on track when you have decided where you want to go. And you have to have a long-term objective. Well, that's very much simple. Then the last thing, you have to be very much structured in your research, and you have to implement a strong methodology. Then what I think is very important for these young oncologists is that they remember that they have old geriatric oncologists that may support them, and I try to push them to ask for the older, to grab the people in the hallways between the sessions and told them, well, you don't know me, but I'm a young oncologist and I would like to develop this trial. Could you help me? Well, I don't have any methodologists. Could you help me? My network is quite limited right now. Could you advise me to do something? Can you introduce me to the national representative of SIOG? Could you introduce me with this guy who is an expert in the field and who may help me? I think that's very important to stress. They have not to remain between young people. They have to be, not to be shy, and get to the older to get some advice. We are here for that, I think. With the older patient, the objective is slightly different from the objective of treatment, is slightly different from what you have with younger patients. With younger patients, your objective is to cure. With older patients, you have to cure, but you have a qualitative side, so that if your patient is alive 1 year after, but in bed, well, that's not a success for sure, that's a real failure. So we go to dual endpoints where you have to control disease, at least, but also to ensure that the patient remains independent with a good quality of life and so on. And there is a lot of place for innovation there. Technically that do exist, but the experience of clinician and statistician is not that good. So I think we have to work on the endpoints, not only by pushing these different endpoints, but also by using a technical, methodological approach. For example, I was talking about a specific trial that was performed where the two endpoints were used. One was survival, and in this place the treatment was not significant. The other one was a dual, but it was overall treatment utility, and it was significant there. So in the elderly, probably we have to think about that. I don't know what will be the solution, if it's overall treatment utility, co-primary endpoints, composite endpoints. I don't know, that's not really the important thing. We have to think in these terms, and to in specific trials, we have to compare different endpoints to make some progress there.